Thank you very much. I'm just going to start by saying I'm very humbled to be here with all the leaders in the room that have accomplished great things. So I'm now retired. I'm just going to talk about my first deployment to Afghanistan. I was 2 years out of residency program. Again, this was my first deployment. I was in Korea for the first 2 years. And I'm going to talk about some of the leadership, I'm going to just call them pearls, that I'm going to share with you during my time at the academy as a cavalry officer and as well as a surgeon in the operating room. So I have nothing to disclose. These are my only conflicts of interest. So leadership and why it matters. So there's a couple of books and one paper that really helped me understand what leadership actually means. The first one is from it was really a medical team, and they talk about effective leadership in times of emergency, and they're talking about disasters as well as mass casualty events. It's actually a very well-written paper that talks about how you perceive things and how people lead teams in times of disaster. The second one is by one of my personal heroes, and that's General Colin Powell. His first book is My American Journey, which talks about how he grew up as an immigrant, a son of immigrants in New York City, where he was a self-professed C student at the City University of New York. And then he went on to ROTC and then went into the military, where as a lieutenant colonel, his senior rater on his OER told him that he had reached his terminal rank. Then he went on to become a 4-star general and then the Secretary of State of the United States. He has a lot of good old-fashioned Army know-how, pearls of wisdom that he shares in that book. And then he wrote a subsequent book after he was Secretary of State called It Worked for Me, where he shares some of his successes, both in the military and outside the military. A great book about leadership for anybody that's interested. So I'll just give you this setup as to what my team looked like during my first deployment. So there was one general surgeon, me, 2 years post-residency. I spent 2 years in Korea before deploying for the very first time to Afghanistan. I had one orthopedic surgeon that was with me who was fresh out of residency from Walter Reed. I had one CRNA lieutenant colonel who was really old and crusty, had never deployed before. I had one OR nurse, one ER nurse, an OR tech that was 19 years old, 2 medics. We did have an actual senior medic that had deployed before, but he had a seizure on the very first day of our deployment and then had to be deployed back home and then never came back. And I had one medical service corps officer who was a first lieutenant that had absolutely no medical experience. Our trauma experience collectively was 2 weeks at the Army Trauma Training Center, and that was it. All these folks were in rear echelon units or in community hospitals where they never did trauma. And our collective combat deployment experience was a grand total of 0. So if you think about it, you're already set up to fail. But why don't we fail? It's really because of leadership. So this is the scenario before this event that I'm about to talk about. So we're 5 months in country. We're at 7,000 feet elevation. We were actually what I consider lucky. We actually did 70 operative cases, predominantly on Afghan national forces and civilian casualties, and we did some humanitarian cases. 70 cases is actually a fairly high operative load for a split FST in the middle of Afghanistan, in the middle of nowhere. Then we went into this prolonged winter. Up to this point, we had no U.S. casualties treated. And then just before this event I'm about to talk about, there were 4 National Guard soldiers that were killed in action 1 month before they were about to redeploy. So morale on the entire base is actually extremely low at this point. This is our actual picture of our forward surgical operating team. So it's basically a shed. You can see the kind of operative OR lights that we have. It's basically just a wooden shed, and we're actually operating on stretchers, not an uncommon scenario for a forward surgical team in Afghanistan. So this is the patient that we get. This is our first U.S. casualty. Pre-hospital report, we have a 23-year-old male who's hypotensive, and they have shrapnel to the abdomen. That's how they described him. There are 4 other casualties arriving with this patient. There's traumatic amputations and a facial laceration. So for our forward surgical team, we have 1 operative bed, so we already know that this is about to be a mass casualty event. So how do you prepare? So how do you prepare for any trauma that comes in your trauma bay? You all do this already almost automatically. You assemble your team, you pre-brief them, you assign roles, and then you have rehearse these scenarios probably over and over again before the patient even arrives. So you basically already know what to do, right? So where does leadership really come into play? So this is Combat Leadership 101. If you go to any of the military academies or have done ROTC, this is a quote that this is probably one of the first things you learn is that no plan survives first contact with the enemy. And that's because the enemy always has a vote. So this is how the patient presented. He didn't actually have shrapnel to his abdomen, but what you can actually see is that there's this, we didn't know this before he arrived, but there's a rod sticking out of his pelvis here that you can see. Sorry, the light's not working, but there's fins on it. And then you can see that whatever this was that was impaling him actually went all the way across his pelvis, and you can see the business end of it, or the tip of it, sticking out the thigh and his other side. So immediately, my plan just went out the window. What I realized at that point was he actually was impaled by a rocket-propelled grenade. So interestingly, we had actually rehearsed this scenario before in the Army Trauma Training Center, which I'll get to. So this is the mechanism of his injury. So this is a Soviet-style rocket-propelled grenade. This is the typical grenades that are used in Afghanistan by the Taliban. And in this particular situation, it had impaled him across his pelvis. So he's white as a sheet from his groins down. So I don't know if he has a major vascular injury, and he's clearly in extremis. So I didn't know any of this ahead of time, right? So I found this all out ahead of time, but it's just, these are just kind of interesting facts about RPGs that I learned after it. So the way they're fired out of a rocket launcher. This is the actual rocket itself. So the way an RPG works is that there's a warhead, then there is a motor, and then there's a booster. So what happens is the stabilizing fins deploy after it's shot out, and then the warhead is actually what explodes. The tip of the warhead is a fuse, and these are really, really basic weapons that are made in developing nations, so they're not very sophisticated. So the fuse is actually something called a piezoelectric crystal. Does anybody know what that is? You probably used it on a daily basis. It's actually in your gas grill. So when you push that button to start your gas grill, and you hear that pop, 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 that's a piezoelectric crystal. So when something impacts it, it actually creates an electrical charge, and the charge goes down the warhead, ignites the fuse, and then the bomb actually explodes. So I didn't know any of this, but we did rehearse this scenario. So what's the first thing I did? I evacuated the forward surgical team because that's what the war surgery manual tells you to do. That's what they tell you to do in the Army Trauma Training Center. So who was left? Me, one non-medical officer, 2 medics, and 2 EOD technicians. So this is where I got really, really lucky, and luck is sometimes better than skill in some cases. There was an EOD technician as well. That's an explosive ordnance disposal team. There was one senior NCO and his trainee that happened to be on the base on that very day, miraculously. So now what's the plan? So this is what the Army War Surgery tells you to do. So patients with unexploded ordnance are triaged last. We didn't know he had unexploded ordnance, so I triaged him first because he was the most hypotensive and unstable patient. The other ones we moved on to the cache. You're supposed to separate them from the other casualties, and you treat them as expectant because they're a threat to the entire surgical team. So before I deployed to Afghanistan, I went to the Army Trauma Training Center for the first time, and this was in 2005. And we actually had a mass casualty exercise, and some of you have gone through this. But they'll have all these pigs with mock injuries. They're actually pigs that have these injuries. And I remember myself and one of the other general surgeons at the time were assessing his casualty, and he's got one of those Nerf footballs stuck in him. You know what I'm talking about? It's got the football with the fin sticking out. And we're like, oh, he's got a rocket in him. Let's take him to the operating room. So we immediately took that patient and we took him to the operating room as a priority casualty. And they told us we failed. They shut off the lights, shut down the operating room, and said, we failed this mass casualty. You're not supposed to take that patient to the operating room. The bomb has exploded. Your entire operating room is destroyed. So I said, okay. So here's Colin Powell's Pearl of Leadership #1. Don't be buffaloed by experts and elites. Experts often possess more data than judgment. When Colin Powell was a second lieutenant in Vietnam as a platoon leader, there's a branch of the Army called military intelligence. They said, we're gathering all this data, we're gonna analyze it for you, and then we're gonna tell you things about the enemy, they're gonna help you. He said what they told him after weeks and weeks of data analysis was this. They said, the enemy likes to attack at night. That was their whole analysis. So don't always believe experts and elites. Again, they usually possess more data than judgment. Powellism #2 is dig up all the information you can, then go with your gut instinct. So there's strategic medical leadership, and you guys practice this on a daily basis. You just aren't aware that you practice this. So what you have to realize, number one, is we talk a lot about individual skills, which are extremely important, especially when you're training, but you are not an individual performer. So what you do is you act like a team and know that you're part of a team, and every member of that team is important. So during times of quiet, that's when you develop your team. You develop organizational values. You realize that every member of that team is important. The OR tech, the pharmacist, the medic, everyone in that room is important. You try to manage their expectations, you mitigate miscommunications, and you develop collaborations. You do that by training and rehearsing. Okay, so here is the first x-ray that we got. So what I realized was the one medic that knew how to use the x-ray machine that was in our FST, I sent him out of the room. So there was one guy that didn't know how to use the x-ray machine, so that's the first x-ray we got, utterly useless. So then that's the second x-ray we got, that was also utterly useless. Then I said something like, if you don't get this third x-ray right, I'm gonna strangle you right now. So finally he got the x-ray right. So what you're seeing here is the rocket propelled grenade, right? This is the propeller of it. This is the tip of it that contains a fuse. This is what the EOD guys tell me. I have no idea what I'm looking at. This is what's not on this RPG is the actual warhead. So right now I'm thinking I'm relieved. Okay, so I'm thinking this is not an entirely lost situation at this point. Okay, but this is how an RPG actually works. Again, so we talked about the propeller, the tube, and then the warhead. These are notoriously finicky devices. They're not made very well, and what will happen frequently is the warhead will actually shear off, because if the very tip of it doesn't impact something right away, and then it skids or bounces or glances off something, the warhead will actually shear off. But what you're left with is actually the fuse. This is what explodes and ignites the explosive main charge here, and the tip of it's actually an empty cone, and it's shaped like a cone for a reason. Again, I had to look all this up afterwards. What happens is that cone turns into a liquid jet, super hot liquid jet that can actually pierce armor. So what happened in this case was the warhead sheared off, but the fuse was actually intact. What the EOD guy didn't necessarily tell me at the time was that this is an incredibly unstable situation. So anything that completes that electrical circuit will make that fuse explode. All I heard is the warhead's not on. So Powellism number 3, perpetual optimism is force multiplier. So I said, great, let's go to the operating room. All right, but then we realized we need to intubate this guy. He's saying over and over again, I can't breathe, I can't breathe, I can't breathe. For anyone that's been in a trauma extremis, what does this actually mean? He's in shock, right? He's not perfusing, and usually the next thing that happens is they go into cardiac arrest. So I call back in the CRNA, patient becomes hypotensive and goes into cardiac arrest. I'm not sure if I can do chest compressions right now. I give epinephrine, and luckily his heart rate and his blood pressure return. We're starting to give him blood and FFP, which is a precious commodity at our FST. I have about, at any given day, 0 to 10 units of PAC cells and 0 to 10 units of FFP. Luckily, I had some on hand. Whole blood transfusion really wasn't a thing. Ubiquitous thing at the time I was deploying during that case. So then what's the operation? So now you have to start planning, and you've now become the leader because you're the guy with the most knowledge about this situation. So what you do is you process and analyze, and now this has become a really complex environment, and so is really any operative case, or any operative case where you have some unexpected event occur, like unexpected hemorrhage or cardiac arrest. So now your reaction time is vastly reduced. Your outcomes are influenced now by a host of non-medical factors. So you're already worried about ethics and legal implications, safety. Now I'm worried about the safety of myself and the rest of the team members. So how do you set your team up for success? In quick decision making, you have to do good situational analysis. Experience really comes into play, and so does expertise. But you have this really junior team. So during that downtime, during that whole 5 months when we really weren't doing anything, it was really important to build that team, build camaraderie, and continue to train, even if you were just doing it in simulated circumstance. So build success, leaders simplify complex situations, and your job has now become to give everybody the big picture. You identify the critical pieces of information, and then you fall back towards directive leadership. In other words, you don't become that guy that gets frustrated because somebody can't put an IV in. You become that guy that says, we need to go to the operating room, here's what we're gonna do, and it's all gonna be okay. Because if you start panicking, everybody starts panicking. So in times of quiet, you also develop team dynamics, and once you have a coherent team, and this is similar to how you practice when you have a sports team or when you're in competitive sports, developing team dynamics actually creates an anti-chaos effect. You build cohesion, you each know how each one is gonna react, you know your strengths and weaknesses, and you do this by behaving like a unit. The military actually does this very well, right? We all wear the same uniform, you have unit symbols, you all have a unifying mission. You rehearse complex resuscitations, even though this is not a situation that we normally would encounter or we necessarily even thought about training about. You learn to train realistically because then you can anticipate things. Okay, and then you have difficult discussions before they happen as well. You discuss ethical dilemmas, you discuss difficult clinical situations, so that at the very least, everybody knows what the right thing to do is in times of crisis. So just to give you an idea of what happened, so there's the Finn, that's the EOD technician, Dan Brown, who's trying to figure out what to do with this because what we're realizing is this thing is not moving. We can't pull it out, we can't push it in, it's going nowhere. So he gets under the curtains and he starts hacksawing this thing. That's just what he does. I said, sounds good to me. I'm just gonna get ready to do this laparotomy. So that's him under the drapes. His assistant is actually filming this while it's happening. I'm making a cut down, avoiding using bovie over that right hip. And what we see is indeed that the fuse is intact as well as the rest of the RPG, but the warhead is not attached. So this is just a video of the actual surgery itself. This is Dan Brown, the EOD tech. He's actually guiding the business end of this towards himself because there's no room to move in this FFST. His back's actually against a wall. There's nowhere else to go. He's wearing a flak vest, and so this thing actually explodes into his chest if it's gonna explode, thereby directing the shrapnel away from everybody else.
Okay, it's coming pretty easy. Okay. Here's the belt buckle. Okay, I felt something.
Yeah, like that's just on this side. You're almost through on this side. Now you're intra-abdominal.
Okay, ready to? Okay, you feed it. I'm holding. Okay, you feed it. I keep coming.
So you're out of this hole here.
Okay, stop for a second. All right. We're almost out. You guys doing a great job. Pull this up. Crank it up hard. You need it.
Yeah.
You gotta get close to the patient.
Yeah, so either
Don't worry about it. Just bump his ass out of the way.
Okay. Ready?
I meant that in the best way possible. Go.
Almost there. About 3 more inches. There's something pulling. There we go. We're clear. We're clear. All right.
All right, so that's Dan Brown. He takes that thing out, he puts it in a bunker that they had created out of sandbags, and then they wrap some C4 around it, and then they blow it up. So this is actually post-op. This is Channing Moss, the soldier that got impaled. You can see the amount of injury he has to his pelvis. He's actually missing at least half of his iliac wing on that side. It had gone all across his pelvis. Luckily, he didn't have any major vascular injuries. That was what I was really afraid of at the time, but his iliac vessels are intact. He had massive hemorrhage. He had large pelvic bone fracture. He had multiple small bowel perforations, and he had his colon was basically shredded by this thing. That's the RPG in the bunker just before they exploded it. So what do you do after this situation? So a leader's work still isn't done even after this event. All right, so you rest and debrief, and this debriefing is so important. I was actually just reminded of this because now I'm in charge of the surgical ICU at Penn State, and when the nurses came to me and said, you know, the nurses, they're really getting burned out because we noticed, you know, they're posting inappropriate things on social media and saying inappropriate things about each other. The morale seemed to be degrading in the ICU, and they said, you know, these are really, really sick patients, and this nursing leadership reminded me that it's really important to really talk about these events after they occur. And I said, that's a great idea. We used to do that in the military all the time. I don't know why I'm not doing it now. So now I'm going to start debriefing the ICU nursing team after each event, especially cardiac event or cardiac arrest or or death occurs in the ICU. You look for signs of fatigue. You look for the late effects. We all know this, what a huge problem suicide is and PTSD is for our military personnel. You enforce arrest. Some of these guys just want to keep on going, but you have to make sure they're taking care of themselves. So finally, Powellism number 5, there's no end to the good you can do if you don't care who gets the credit. So this is Billy Mariani. He's actually the platoon leader that led his platoon on that mission, led his platoon through the kill zone, got them out safely, and then told Channing Moss that it was all going to be okay. This is Jared Angel, 20-year-old medic that took care of him, kept him from bleeding to death at the scene. Even though it took hours for that patient to get to us, he was still alive when he got there. That's Dan Brown, the EOD tech that, thank God he was there, because actually if he wasn't, I have no idea what I was going to do that day. That's Kirk, Kevin Kirk, who was the orthopedic surgeon who had never had his hands on an aorta before, but he did that day. And he was still fresh out of residency, so he still knew what an aorta was and where it was, so that was great. And that's the medevac team led by Chief Warrant Officer Jose Correa. Their SOP was also not to fly a guy with unexploded warrants. They were supposed to leave him there, but they all decided that they were going to fly this guy out and get him to our FST, and thereby saved his life. And there's Channing Moss, who survived this incident. So again, it was a team effort. I think my leadership only had a very small part to do with it, but I think we all have to realize that we all can become leaders in these crisis situations. So thank you for the opportunity to talk.